Well, thank you very, very much for the warm welcome, and my hat's off to all of you for how well you were able to pivot very quickly, a really important conference, and to turn it into a virtual event. Today I want to tell you that through the course of the presentation, and it will be we'll try to keep it a shorter presentation with some time for dialogue, which is hard to do dialogue when you're virtual, but Melissa Skarupa's promised to help me out here. And if you can just keep the comments and your questions flowing through the chat room as we go along. When we get to the end of the presentation, Melissa will read out those comments and questions, and we'll also have a couple opportunities to interact through the course of the presentation with some poll questions. And then I just want to let you know that I don't usually speak with employers and businesses, so so forgive me if I slip into doctor talk and madly chat and tell me to remember to speak human and not to speak in acronyms, but I'll do my best not to let that happen. So let's start off and talk about some fish. And think about this fish as maybe an individual in a community. And this fish is really a very happy fish swimming around in their clean fish bowl. But the fish all of a sudden has a health event, a heart attack, a stroke, a broken leg, maybe even COVID-19. And this fish has access to the best fish doctors that you can imagine. We've got the fish intubated there. We're doing a very highly technical surgical procedure, and the quality of that healthcare is excellent. This fish is in the best goldfish doctor hands that you can imagine. Well, once that fish recovers and does well after their surgery, that fish goes right back to their fish bowl. And we would all expect that fish to have a good, healthy recovery, to return to a functional status where they are happily swimming in their fish bowl and doing all the things that fish do, which probably aren't too many in that fish bowl, but anyway, that fish is doing well. But I want you to think about this fish. And I want you to think that this fish has that same condition that that previous fish had, a heart attack, a broken leg, a stroke, COVID-19. And I want you to think about this fish going to that same team of excellent fish doctors. They are operating well, they are taking care of that fish. But then think about this. What do you expect the outcomes are when a fish gets returned to a fish bowl that looks like this? I don't think any of us would expect that this fish has the same opportunities to return to a healthy life, a full functional recovery as that fish in the previous fish bowl. So let's start off with the question. If you can think about all of the factors that influence your health, just a wild guess, what % of your health and well-being is related to access to clinical care and the quality of those healthcare services? So it looks like we've got, we're almost a third. Very few people said 100% of your health is due to healthcare services. And the rest was a pretty even mix from 20% to 50% to 80%. All right, and then Melissa, I'll go ahead and advance if you can remove that poll. So the right answer, although certainly an answer of debate, is that healthcare, access to healthcare and high quality healthcare services accounts for about 20% of the total equation of health. This is information that came largely out of the University of Wisconsin work over the last several decades, but has been validated in multiple different studies. When we look at the other drivers of health, or you'll hear the term social determinants of health, we notice that health behaviors, for example, your use of tobacco, diet, exercise, how much alcohol you use, the physical environment that you live in, what is the quality of your water, say if you lived in Flint, Michigan, or your air that you breathe, or the safety of the environment where you are living. And the socioeconomic factors, including your education, your employment, for all you employers out there, your family social supports, your income, your community safety. Those social determinants of health account for 80% of the equation of health. And I cannot advance. There we go. So you will hear again, you've heard me say social drivers of health, social determinants of health. It's really the same thing. I don't like using determinants simply because I'd like to think that my health isn't completely determined, but there are definitely influences that drive my health. These are the circumstances in which people are born, grow up, live, work, and age, as well as the systems we've put in place to deal with illness. These circumstances are in turn shaped by a wide set of forces, economic, social, policies, and politics. In other words, that fishbowl has a much greater influence, the state of that fishbowl has a much greater influence on your overall health than the quality and the access to healthcare services. So how much does it impact? Here's a slide that just highlights some of the influences and the degree of influence that the social drivers of health have. Housing instability can, and homelessness can reduce your actual life expectancy by, look at this, 25 to 35 years of reduced life expectancy for those who experience homelessness. For those who are food insecure, and we know that we've seen a lot more food insecurity now with COVID-19, 3/4 of those homes have to make a decision about whether or not they're going to pay for their food or for medicine. 2 times greater mortality for those who are financially insecure. This is just a striking fact that social isolation can contribute to increased mortality and morbidity by a full 30%. And this is very important during these times of COVID-19. And then the gap in life expectancy due to differences in education. So whether, least of all, that you think that these are just sort of big national numbers that we should be looking at, I want us to look a little bit right here at our own state in New Hampshire. This mantra of your zip code is a better predictor of your health than your genetic code is a mantra that we hear more and more amongst population health scientists. And it's as real here in New Hampshire as it is anywhere in the United States. Hanover, New Hampshire. If you are born in Hanover, New Hampshire, your life expectancy at the time of your birth is 85 years. Just 37 miles away in Newport, if you're born today, your life expectancy is a full 10 years less than if you were born in Hanover. This is not related to access to healthcare. We can, all of us, get to Dartmouth fairly easily, but it's related to these social drivers of health. Look at the difference in median household income between Hanover and between Newport. Look at the percent of families that are living at less than 200% of the poverty level. These profound differences in these social drivers of health are what drive the large health inequities and health disparities that we see. So what do we do about this? This is the focus of population health. Population health is both a goal and a strategy to foster healthy equitable populations through the intentional alignment of clinical transformation and community-based approaches through innovations and investments. We can't focus on just what happens to that goldfish when they go into the hospital. We have to also focus on the goldfish bowl that they live in. And employers have a huge impact on these social drivers of health. In fact, you know, if you think about it, between employment and education, you really have almost, you're touching almost every social driver of health. What is the culture of health that you've created in your place of employment? What are the wages that you're paying, which determine the income of the employee and their family? What offers do you have for health insurance for your employees? What policies and practices do you implement in your place of employment that promote or get in as a barrier to healthy living? Do you have a no smoking campus? Do you offer healthy foods in your cafeteria? Do you offer paid sick leave? What education and training are you investing in your employees so they can advance in their jobs and in their professions? And what's the physical environment of the place where you're employing people? So employers have a major, major impact on these social drivers of health, which again impact 80% of our health. So alas, here we are dealing with now a pandemic that's unprecedented and creating greater health challenges than we've ever seen in our lifetime. So let's go to the second polling question, Melissa, if you could pull that up. Okay, this is poll number 2. The coronavirus has been described as the great equalizer, but there's a growing awareness that severe COVID-19 disease is more likely in which groups of people. And this one, there is an all of the above at the bottom, but the first one is a pre-existing chronic disease such as diabetes and hypertension, obesity, African American, the poor or impoverished, or all of the above. I think let's close that. Excellent. So the vast majority of people picked all of the above, and the evidence bears that out. It is all of the above. What you've heard in the news, and this certainly contributes to the angst that our country is going through right now in terms of the outrage with the state of affairs for our African American population. We know that patients with COVID-19, the African Americans have borne an disproportionate amount of disease and death. This graph shows you in one graph the percent of the population in several of these locales located down the y-axis here, District of Columbia, South Carolina, Michigan, etc. The percent of the population is the gray dot there. And the proportion of COVID-19 deaths that are represented by African American in that state are the green buttons. So you can see that in the District of Columbia, the proportion of population in DC is 44% African American, but the proportion of deaths account for a full 80% from COVID-19. These types of data highlight the enormous health inequities and disparities in our country. Why does this occur? Certainly we don't have all of the answers, but at least some of this answer is due to the fact that our African American population for years have dealt with a higher burden of chronic diseases, that there's been racial bias in our health systems, and that that may well serve as a barrier to people when they go to seek care. In terms of rates of coronavirus disease in New York, again, we have seen profound differences in not only the rates of disease. The graph on your left is the patient hospitalization per 100,000 population, And the graph on the right are deaths per 100,000 population. And you can see that the Bronx has been disproportionately impacted by COVID-19 when you compare the Bronx to, say, Manhattan. The Bronx are a borough with the highest proportion of minorities and the most people living in poverty with the lowest education attainment rate, in contrast to Manhattan, which is the most affluent borough. So why would this happen? Well, if you think about patients who live in the Bronx, low education level, probably low wages, working in jobs that are not jobs that allow them to telecommute, but these are jobs that force those patients to leave their borough, to get on public transportation, to go to stock the grocery stores, or to go to clean a facility. These are low-paying jobs that probably do not offer any paid sick leave. So people are making a decision about, I have to go to work even though I'm ill because I can't afford to lose my wages. They may live in more housing, more crowded housing situations. And all in all, they are more challenged by those social drivers of health. It's a dirty fishbowl compared to Manhattan, which is that clean fishbowl that we first saw. Unless we think that these are all problems of big cities, I just want to really quickly show you some data from New Hampshire. This is the difference in rates of disease across the counties in New Hampshire. Looking first to the left of adult cardiovascular deaths for people over the age of 35, and then obesity, and then diabetes. And we know from looking, just to give you kind of an idea of the differences here, in the rate of cardiovascular disease, there is a 30% difference in from the highest county to the lowest county. And we see in obesity, again, the percent of population that is obese, again, about a 30% difference from highest to lowest. These inequities in our health and chronic disease in New Hampshire are as profound here in our state as they are elsewhere. And when we compare that disease inequity, and I just picked one of these charts, I picked the cardiovascular deaths. Look at how it matches up to education, percent of population with less than a high school education. In the highest, which is the darkest area, it matches up perfectly with the northern area with a high cardiovascular death rate, and also patients or populations receiving food stamps and SNAP benefits. Again, these are highlighting the fact that disease is not, it is profoundly, chronic disease profoundly impacted by these social drivers of health. The coronavirus didn't break the United States, but it's revealed what was already broken. In the years of, for many years, we have spent more on healthcare in the United States than any other country on the globe. And yet our health outcomes are not nearly what our other brothers and sisters in other developed countries have. We have lower life expectancy, higher perinatal mortality, and higher rates of death from preventable causes. So how do we put this all together? And I think the way we put it all together is that the United States has invested a great deal in healthcare services. 20%, nearly 20% of our gross domestic product goes to healthcare services, but we have far underinvested in the social drivers of health, our education, our housing, our food security, our employability. We have far underinvested compared to other developed countries. So I want to take us back to the old days when all we had to deal with in New Hampshire was an epidemic. We didn't have to deal with a pandemic. Our epidemic in New Hampshire was our epidemic of deaths from overdose fatalities and from the rising rates of suicide and alcoholic liver disease. And when we look nationally across the United States of America, our life expectancy fell in 2015, 2016, and 2017. And two Princeton economists, Ann Case and Angus Deaton, looked into why are the citizens of the United States of America, the richest country in the world, having a drop in life expectancy. And what they found were that we have an increased rate of death in our middle-aged white population from suicide, overdose, and alcoholic liver disease, which they called the deaths of despair. And quoting them, they said, these deaths of despair have been accompanied by reduced labor force participation, reduced marriages, and an increase in reports of poor health and poor mental health. And what we can see is that people are less able to form stable marriages, and in turn that has an effect on the kind of economic and social supports that people need in order to thrive when you have a lower education level. In fact, what we know is that the coronavirus is just one more step in destroying and undermining the lives of less educated Americans, and will certainly contribute to ongoing increases in the deaths of despair. In fact, we talk about deaths from COVID-19 surpassing 100,000. We've been at 150, 160,000 deaths of despair for the last year. So we are really facing this pandemic at a time when our overall health is very fragile. I'm going to move a little more quickly through these slides so that we have a chance for some interaction. But I want to move us next into our last polling question, and Melissa will bring that up at this point. So this question, you get to choose as many of the answers that apply to you. And I want to ask you as respondents to comment how your business or organization has changed in response to the COVID-19. Have you changed work practices to protect your employees and customers? Changed policies related to leave, say sick leave, use of earned time, etc.? Work to address childcare challenges? Partnered with other businesses or community organizations to support both your employees and your community, or partnered with a healthcare system, a hospital or clinic to try to address the impact from COVID-19. So I'll just give a minute and then we'll finish up. Great. It looks like we're pretty stable here. And it looks to me like pretty much everyone has changed work practices to protect employees and customers, certainly top of mind for all of us. But a good proportion of you, 2/3 of you, have also been adjusting your policies and working with employees to address childcare challenges, which has been a major concern for all of us as the schools have closed. And then working with other businesses, about 1/3 working with other businesses or community organizations to support communities, and only about 1/4 with the health system. So let's see if we can actually make a difference there. So employers, as reiterating, if we looked at the role of employers in terms of determining or influencing those social drivers of health, and I think more than ever, we need our health systems to get ready for this pandemic, but boy, are we looking to you, all of you as employers, to help heal our communities. You have to prioritize adopting practices to keep everyone safe. Focusing on how do we maintain access to healthcare through employer-sponsored health insurance and benefit design. We heard earlier today the importance of providing mental health support and ongoing substance use disorder support for your employees and for family members. And then to engage in social innovation. And what do I mean by that? I mean to really look for new partnerships that we can collaboratively work together to address the overwhelming impact of this infectious disease. These may be considerations such as where are you making purchases? Who are you deciding to expand your supply chain with? Are these new organizations that you're purchasing from, are they local? Can you keep dollars in our communities? Can we keep our dollars here in New Hampshire? Can we make sure that we're purchasing from organizations and businesses that have an explicit mission to improve equity and diversity in their workforce? Where are you hiring? Are you targeting hiring new workforce from areas that have been particularly hard hit? And are you targeting your hiring priorities to ensure that we have good representation of all socioeconomic and racial populations in the workplace? And where are you making investments? Are you using your portfolio investment in such a way to benefit the state of New Hampshire and our communities of color and disadvantaged? In the last minute here, I just want to share an example of what Dartmouth-Hitchcock Population Health and Dartmouth-Hitchcock Health have done in response to COVID-19, and to really celebrate these new partnerships and the importance of partnerships. We've worked hard on transforming the delivery of care. We have stood up new areas in the hospital to treat patients with COVID-19. We've implemented an entire new process for testing and screening and keeping our patients safe. And we've adopted telehealth, and just, it seems like the switch of a light switch. We've also really worked hard on disseminating the knowledge and the expertise of Dartmouth-Hitchcock experts throughout the community. Many of our physicians have been consulting with DHHS and public health, and we also have sponsored several teaching opportunities and learning opportunities called Project ECHO to meet the needs of primary care providers and community health workers. And in fact, we have sponsored a Project ECHO where we've brought together occupational health experts at Dartmouth-Hitchcock to meet with employers, and about 150, 170 different employers and community-based organizations have joined us on weekly learning sessions through Project ECHO. And I really want to focus on the community partnerships that we have participated with, Upper Valley Strong, Greater Sullivan Strong. We've been members and helped support bringing together community partners to be able to coordinate relief efforts and to distribute funds in a way that can benefit the greatest number of community members and to really address those urgent needs. And the Dartmouth-Hitchcock philanthropy engine has really done a great job, our philanthropy and development team, of activating the DH philanthropy arm to raise funds to invest in communities. And these are just a few of the examples where Dartmouth-Hitchcock has said, we can't do this by ourselves. Even if we have the best clinical care in the world for patients with COVID-19, we know that the impact of this disease extends far beyond the health system, and we must work in partnership with our communities, with our employers, to heal our communities. So I believe that this is really a time of truly great optimism. We are dealing with challenges clinically from COVID-19. We're dealing with challenges racially and socioeconomically across our country. And I believe that fate is not going to determine our future. I believe the choices that we make will determine our future. We know that the health of our individuals and our communities require new partnerships. We must have our health systems working alongside our employers and our other community organizations. I have no doubt we will create a vaccine for the coronavirus. I hope that together we will create a medicine to deal with the inequities and the disparities in our social conditions. And I think that we will all have new roles in our new future. We're going to reach across the aisles. We're going to reach across communities. We're going to reach across the traditional silos that we've worked in, because with the new partnerships that we will put together, and indeed we have already started working together, I believe that we will create the most powerful medicine in the world to address not only this infectious disease, but the health inequities and disparities that have marred our populations for years. So with that, I'm going to end on a really hopeful, optimistic note, and hope that together we can create this clean fishbowl